afternoon, everyone. My name is Gina Petty, and I'm the Executive Director of the Children's Cardiomyopathy Foundation. I'd like to welcome you to today's listening session, Pediatric Cardiomyopathy Care Considerations. Whether you're joining us today as a patient, parent, caregiver, medical professional, or supporter, I am certain that today's discussion will be robust and filled with meaningful insights and takeaways for all of our attendees today. We would like to take a moment to recognize our corporate sponsors noted on the slide for their generous and ongoing support of our educational programming. Thank you all so much. The Children's Cardiomyopathy Foundation, or CCF, is a nonprofit organization dedicated to finding causes and cures for pediatric cardiomyopathy through the support of research, education, awareness, and advocacy. Established in 2002, CCF has grown into a global community of families, physicians, and scientists focused on improving the diagnosis, treatment, and quality of life for children with cardiomyopathy. This listening session today is being recorded and will be available on the CCF website in the coming days. If you have questions or comments during the discussion, we invite you to share them using your Q&A box on your control panel, and we will address what we are able to during today's discussion. I'm thrilled to be joined today by Dr. Stephen Lipshultz to moderate today's session. Dr. Lipshultz is a professor of pediatrics at the Jacobs School of Medicine and Biomedical Sciences at the University at Buffalo. His primary research interests are in pediatric cardiomyopathies, especially those of genetic, metabolic, or inflammatory etiologies. Clinical research on determinants of outcome for children with cardiovascular disease has been a major focus of interest as well. Dr. Lipshultz serves as Chief Medical Officer at the Children's Cardiomyopathy Foundation, is lead of the Pediatric Cardiomyopathy Registry, and is co-chair of the 6th International Conference on Cardiomyopathy in Children. This meeting is taking place virtually May 10th and 11th and being jointly hosted by the Children's Cardiomyopathy Foundation, Pediatric Cardiomyopathy Registry, and Cincinnati Children's Heart Institute. Without further ado, Dr. Lipshultz will now share some opening comments and invite our participants to introduce themselves. Thank you all so much for joining today.
Thank you, Gina. This is really such an important opportunity in this listening session to really promote the kind of dialogue that leads to the highest quality of life for children with cardiomyopathy and their families and their extended care teams. And with that, we recognize that over the past 20 years, we've had 5 international conferences on cardiomyopathies in children. We focused mostly on the provider community globally, and we're really pleased that during this last 20 years, there's been measurable improvements in the medical management and quantifiable outcomes for many children and families living with and beyond cardiomyopathy occurring during childhood. But some of what we realize in our CCF, that's Children's Cardiomyopathy Foundation supported research, has shown is that parents, families, patients often have some of the most important insights, and their comments and their thoughts and their concerns are oftentimes the strongest predictors, more than anything else we have, on who's going to do well and who may not. And so to try to promote the idea that now what are the most important factors from the perspective of parents and families? What are those questions that come up? What are the concerns that are perhaps not always addressed? And how can we, as the Children's Cardiomyopathy Foundation has worked hard over the last 20 years to help promote and create centers of care, centers of excellence that have multidisciplinary teams to try to address many of these concerns. We're really pleased that today we have a wonderful mix of caregivers, family members, and I'll go over each of them and um, and members of our CCF Centers of Care Excellence at centers. And let me just go over each of these wonderful people that are listed up there. The first one, Dr. Nadine Kasparian, is a professor of pediatrics and director of the Heart and Mind Well-Being Center at Cincinnati Children's Hospital. She received her PhD in medical psychology from the University of Sydney in Australia and a Harkness Fellowship in Healthcare Policy and Practice at Harvard Medical School. Nadine has established in the past one of the first psychology programs dedicated to congenital and childhood onset heart disease. And her research is focused on understanding how early medical adversity may alter developmental processes, including emotional regulation, stress activities, in ways that increase vulnerability to anxiety and depression later in life. And at this point, she serves as the co-vice chair of the Cardio Neurodevelopmental Outcomes Collaborative and the research co-lead for the Fontaine Outcomes Network. These are multi-center studies. She's an author of the American Heart Association Scientific Statements and recently led the mental health and neurodevelopmental charters of the Australian National Standards of Care in childhood onset heart disease. She will be one of the keynote speakers in the 6th International Conference on Cardiomyopathies in Children occurring in May. All of you who are currently listening are certainly invited to register, participate. Registrations online. Her experiences with working with families and children with cardiomyopathy is extensive and helpful. Joining her is also one of the speakers at the 6th International Conference on Cardiomyopathy in Children in May is Kyle Landry, a former elementary educator who's the founder and manager of the Educational Achievement Program at Children's Hospital in Wisconsin. And over more than 9 years of program growth, Kyle has built a team of experienced educators specially trained in neurodevelopmental sequelae of chronic illness and interconnected complexities of physical, mental, and social health on learning. Her work has led to several research grants, authorship in a nursing textbook, and 3 medical journal publications. She has a bachelor's degree in early childhood education, a master's degree in cultural foundations of community and education from the University of Wisconsin, and she's currently pursuing her PhD in healthcare leadership. We are also really, it's a real privilege to have with us 3 caregivers that have been active in the Children's Cardiomyopathy Foundation, offering terrific suggestions, advice, insights. Regina Vaughn is a mother of a child with dilated cardiomyopathy and brings a wealth of personal insight and experience that we sincerely appreciate and will be participating actively today. Renee Stewart is caregiver for Benjamin Stewart, her son, who has also dilated cardiomyopathy. Renee has been active in CCF, Children's Cardiomyopathy Foundation activities, and offered tremendous insights to CCF, including participating in this conference and offering written suggestions and insights. Karen Wellman is a 3rd caregiver. Her son, Luke Wellman, is is a child with hypertrophic cardiomyopathy and has tremendous experience over a substantial period of time in working on behalf of Luke's care with care teams and family. And we appreciate very much all of her help to CCF, her advice, her insights, and even her written comments and suggestions. So these are the 5 participants in today's learning meeting. I'd like to start. I'm going to go around the horn a bit after I ask Kyle Landry to give some thoughts Kyle put together in anticipation of this. 5 areas where the thought was, from years of working with families and working with care teams, that there really were opportunities. One was the heart-body-brain connection. And we're identifying neurodevelopmental risk factors with school staff, teaching teams, having little education on how the heart, body, and brain are connected. And as a result, many well-intended teachers misidentified delays and miss important opportunities for early intervention. Kyle, do you want to explain that a little bit more? And then I'll use this as a way to see how some of the panelists react to that with suggestions and thoughts. So this is having a child with cardiomyopathy, and how do you work with schools, with educators to maximize opportunities?
Absolutely. So backing it up very briefly to my background is I started in education. I was a teacher. I had no intention of leaving education. And I had a student have a medical event in my classroom. So I was by myself with 36 kids. I was trying to help the student, had 911 on my phone, calling into the hall for support, and no one came. The child and I were transported to our children's hospital, and we found out that he had a known cardiac condition, and information was never shared with the school team at all. So I went through all of these stages of blame and shame and grief and all the what ifs, and kind of landed on asking this mother to partner with me and tell me all of the reasons that information wasn't shared so I could do something about it. So next time another family, another student, another teacher wouldn't have to go through, hopefully, a scary situation like I did. And what we found is that mom had a lot of fear of her child being labeled, of him having lower expectations, all of the stigmatizing things. And I really worked with her, kind of like what we're doing today, to get all of her information, the whys and the what could we do better, so I could promise her as a healthcare system, at least our local children's hospital would do better. And ended up pitching her ideas to Children's Wisconsin and stepping into the role of the position to then build the program. But the heart, body, brain connection, one of the first things we did was ask schools. I met with 20 Wisconsin school districts, 17 school nursing teams, and asked what they knew, what went really well, what they didn't know, what they needed support with. Because the one thing I knew as a teacher is I was not going to go into a school and tell them what to do without having asked them what they need. So what we found out is teaching staff often knew that the child had a medical condition, whatever it was, but they often did not know that it could increase the susceptibility to illness, that it could increase the risk for developmental delays, and that we could see educational challenges in the classroom that might seemingly be unrelated. So let's say maybe ADHD, attention and behavior, not realizing it could have been connected to a cardiac condition that the child was born with. And from that point began scaffolding a program and services that would help educate families on what language they could use to share with their school teams how the heart, body, and brain are very connected, what language we could share with the teaching teams to teach each other, and also our medical providers and partners, what language they could use with families to help teach how the heart, brain, body, or health in general, body and brain are connected. So everybody was more informed and more empowered.
Great, thank you. And now I'm going to end on this topic ultimately, Nadine, but I want to see if Renee or Karen or Gina, if you have any thoughts on this topic. Have you had issues? Do you have suggestions on dealing with schools, with educators, with physical education, with developmental assessments? So let me just kick it off around. Renee, do you have thoughts on this? You're nodding your head affirmatively.
Absolutely. Well, thank you for the opportunity to join you all today to talk about this. This is something that's obviously very important to me overall in my journey with Benjamin. I can certainly relate to the story that Kyle shared in terms of the stipulations that come with a diagnosis like cardiomyopathy, and the preconceived notions that educators will have. And my experience, I've had one or two cases. One, they have no idea what it means and they don't care to learn it. Or the other, in the extreme side of things, is it's, oh my gosh, I have this heart kid. I don't know what to do. I don't understand this. He can't participate in gym. He can't do these things. And it puts a little extra burden on the parents to facilitate those conversations a lot of times. And unfortunately, in the digital world that we're in right now, most of those forms are now online. So you're not even, having that dialogue with teachers. So, it's really on the parent to reach out and have that conversation and make them understand, this isn't going to be, this isn't a liability on you. We just want to educate you so you are best, served to handle anything that may come up in the classroom.
Karen, your experiences with this, is this something that's
Yeah, so my experience is different than the story that was shared, in that as soon as my son was diagnosed, I wanted the nurse at the medical team at the school to know about it. I wanted my son's teachers to know, that we had a diagnosis and that we were going through to get a care plan, because I felt like, I didn't want an incident to happen and for them to be unprepared. And I wanted to make sure they were prepared to handle a situation that might have come up, but fortunately it did not. And also my son is ADHD. So while we were developing the care plan, he had to come off those meds to see what we're going to do down the road. And I just wanted them to be aware, and the school, of course, didn't know anything about the nurse did at the school. She happened to have she had some heart problems in her family, so she did at least know about HCM, so that was good for me. And she was really a good support system for me as well. So it made me feel a little bit more comfortable about what my son was facing at school. So it really helped.
Regina, any thoughts, experiences, comments, insight?
So my daughter is going to be 3 in June, so we're still, and she was just recently diagnosed. So we're not quite at school age yet, but I did because we've transitioned with early intervention to preschool, which the school district takes over. They're aware of it, and I was actually really pleased with how they took the initiative to reach out to me and have a meeting and ask the questions to kind of preemptively get plans in place before she'll start preschool in this school next fall of 2025. So, my experience is still limited right now with this school district, but I am very happy with, I initially shared the information about her condition, and they are very much on top of it, already planning our next meeting in December to kind of get a medical and emergency plan in place, as well as her IEP plan as well.
Good. Nadine, listening to this, I'd love you to share all your experience and wisdom and suggestions here before we move on to the next topic.
Well, thank you so much. Thank you very much for inviting me to be part of this conversation. Carl, you're a force of nature. I mean, what you just shared and how you were able to take something that was so catastrophic, so traumatic, and turn it around and then have such a ripple effect in the community is just incredible. So thank you. You really are the expert in this area. I think the example that you shared and the work that you do really shows the importance of all of us moving beyond the walls of the hospital and into our communities and engaging with our communities, with patients, with families, with caregivers, and with schools and other community organizations to create those bridges and those connections. I know in some of the research we've done several years ago, one of the strongest unmet needs or the greatest unmet needs amongst parents of children with cardiomyopathies was that connection with schools. And so, from the conversation we're having today, we're really seeing that tide turn. And I think in addition to the importance of that conversation and that continued education from a teacher's perspective and a family's perspective, what we see it do for children can also be really incredible. Often children with these conditions can feel like the only person in the world with this kind of heart condition, being able to create conversations with their peers and ways in which others can understand their experiences and create a dialogue around those can be incredibly therapeutic for children and families as well as the class as a whole.
Good. Well, thank you. So now Kyle brought up an important second point, and let me use that as to do the same thing we just did with the heart-body-brain connection. The second point she titled Parent as the Project Manager. And what she wrote is parents are responsible for sharing technical medical information, often while navigating equally complex education systems. And providers have opportunity and potentially responsibility to empower families with information, language, and resources to become the project managers of their child's education. Kyle, do you want to expand on that?
Absolutely. So what we found is this work, like Nadine was saying, this care coordination between the medical team or the hospital team, the families, and the schools. There's like this gray area where everybody kind of goes so far and then relies on the other one, and it becomes this like, whose job is it to take that extra step? So one of the things my team does is we coach families on how to be the parent, how to make the parent the project manager. So how to get the necessary information from their providers, how to explain that information in schools, how to manage their child's IEPs. A lot of families say like, whoa, that's on the school to do. I participate and help build it, but they need to carry it through. And it's kind of like, a school, everybody's doing their best, right? There are so many barriers everywhere you look. But that child that's going to get the best services and supports is the child from the family that says, I'm going to take my own data. I'm going to show up at every meeting. I'm going to actively participate. And then helping the schools make sure the families have all that information to be active participants. So basically the EAPP feels really strongly on coaching and supporting families to be the project managers. And really everybody has a role in that, starting with our healthcare providers, helping give families the language and the resources and tools like Dr. Lipshultz said.
Well, thank you. Now, Renee, you are kind enough to give 5 bulleted, really important points. And each of these really relate exactly to this topic of the parent as the project manager. So with your permission, I'd like to share this with the 40 people who are participating on here and ask you to comment. Your first bullet was patient connection is important. Even though they're kids, include them in the conversation. Your second bullet, really important. Understand the importance of the initial diagnosis conversation. Your third really important point. Know when is a, quote, teaching moment, end quote, and when it's only between the patient and the doctor. Your fourth bullet was consider the timing and familial implications of genetic testing. And your final point that you shared with us was educate your families, which is really relevant to this topic of the parent as the project manager, on not just medical language, but also scope, ejection fraction as an example. Why don't you expand on these 5 points, especially as it relates to the parent as the project manager?
I'd be happy to. I think that accurately describes how a lot of parents feel, especially in the beginning, having to disseminate information to all of the different individuals in your lives. And it really, those conversations and the quality of those conversations starts with the discussions between the providers and the caregivers. And in terms of the education, what I wanted to talk about with points 2 and 3, in our journey when we were initially diagnosed, the place where we were, which is not a CCF center of care, utilized that moment to be a teaching institution. So here I am. I was by myself at that time because we had an older child that needed to be picked up. We had not yet gotten the full diagnosis. My son, when he was being diagnosed, was an infant. And here we are overwhelmed, not understanding what's going on. We knew we were being admitted, and the hospital brought in 10 to 12 people in our room to give us our initial diagnosis. And I wasn't even processing what they were saying. I mean, I honestly, I kind of liken it to feeling like an animal at the zoo where everybody's just staring at you. So I completely didn't even understand what the diagnosis was at that time. I absolutely understand the importance of teaching and hospitals being a teaching hospital, but that wasn't the time to have that discussion with those folks. On the upside, when I was talking to my son, who's now 13, I asked him in preparation for this, I said, what would you want me to relay? And he said, Mom, just tell him to find a Dr. Schomburger, somebody who connects with me, who talks to me, and is making me the priority in the conversation, which I thought was really insightful for a 13-year-old. And then from my standpoint, the connection that we have with our doctor is that education piece and helping us understand the language, understand. So ejection fraction is an excellent example in my mind of where you need to educate families. So when we were initially diagnosed, my son's ejection fraction rate was around 20%. Most people, when they hear 20%, they think it's out of 100%. I mean, it was obviously still very, very poor, but I'm thinking, oh my gosh, 20% out of 100. We didn't end up learning that a healthy ejection fraction rate is, between 55 and 70%. So it's things like that, whereas, as medical professionals, it's obvious to you because you've had that training. But for families, we don't know that. And the internet is a very scary thing when you get an initial diagnosis that you want to stay away from. So again, that just stresses the importance of the providers helping educate families along that path.
Very good. And then Karen, you were kind enough to share some really important points from your background and experiencing, and I'm hoping it's okay if I can share the 4 points you brought up, because many of these similarly relate to the topic that Kyle was discussing, the parent as the project manager. And if you're going to be the project manager, you have to be the owner of the information in a way that is understood and can be communicated. So in your case, your first point was basic information about hypertrophic cardiomyopathy would be helpful because most parents are in shock. a handout, a trusted website, a book the doctor recommends. Your second point, online contact with the doctor or medical professional for non-urgent medical needs would be beneficial. Most offices, medical groups have a My Chart where you can reach out to the medical staff, and the staff generally gets back to you in 48 hours. This can be used for general questions or symptoms you notice and need to know more about. This would be very helpful given that most parents are in shock and don't always know what to ask when they have time with the doctor. Your third point of 4 was a referral to a support group for questions about nutrition and what your child can and cannot do, as we are always looking for a way to help our children. Not that nutrition is going to change the diagnosis. However, as the parent caregiver, you want to give your child the best support and environment. And your fourth and final point, again, it relates to this topic of the parents as the project manager. If the doctor notices emotional anxiety in the parent or child, a suggestion to get help. I appreciate personally you sharing those really good insights. And do you want to expand on those a little bit?
Yeah, I'll just say, I think probably like most parents, you don't know how to, you're getting all this information, the doctor's trying to be very helpful and sharing your child's diagnosis, and you're hearing all these terms that you don't understand. And you don't, at that point, you don't even know what to ask. Because I was surprised. I guess my son had a lot of subtle symptoms along the way, and had been kind of misdiagnosed with difficulty in breathing as asthma. And I was not expecting this kind of diagnosis or this news. And you're sitting there and you're trying to process everything and you don't know anything about this. And it was, and of course, I'm a big researcher as far as going out and checking things out online. And I know you can't believe everything that you read. But I I we went home and processed it, and then I had a whole long list of questions. And it was very helpful for me to get to know how to use the My Chart, which I think most doctors' offices can provide that now, because I felt like I had a lot of questions after I'd researched and thought about it more. And it really made a big difference that I could feel like I could go ask non-urgent things out there, um, to get help. Because when we got referred from the pediatrician to the cardiologist, um, with a heart murmur, I have a heart murmur. I've never had any problems with it. It's not a big deal, but this was a whole different situation with our son. So it's having that support from your medical team or having them refer you to a support group, I think is very helpful to take you along the path, and you're getting educated every time that you get information from your doctor team. So I found the My Chart and some books that I read, to really help me along to see how I could help our son.
Good, good. And then I notice, Regina, as you were listening to Renee and Karen, you were nodding affirmatively. Before you go on, I just wanted to bring up that when Karen was speaking, she mentioned reliable websites for information and others. And Gina put in the chat to everybody. I'd like to put in a plug for CCF educational materials, school resource kits. This is a great resource for parents and schools to work together to support children with cardiomyopathy. And she put the link in. And Joseph Hillenberg wrote in the chat, agreed on talking with and 2 kids and not treating their presence as passive. I couldn't agree more with that. So with that, Rachel, share your thoughts.
Yeah, so one of the things that kind of came to mind when Renee was talking about like knowing when's a teaching moment. The hospital, my daughter was admitted September 7th of 2023 after we were just like calmly sitting at a follow-up appointment and her heart rate was through the roof. And it is a teaching school. So we, you know, like I've known that. I've always known that hospital was. But I think I had a different experience in that we were kind of informed while we were in the ER after they did the EKG and the echo, and then we were admitted upstairs. And they always kind of asked us if you know, could the students come in, or I don't know if they use the word students, but to listen to her heart because she had this gallop sound, and so we were always asked, which I appreciated, you know, not knowing kind of Renee's experience of it, but I'm thankful kind of looking back now that that was our experience. But one thing that just in hearing everybody talk, I realized with the resources kind of being offered that maybe it's not common in the hospital we were at that kids just come in and get diagnosed with dilated cardiomyopathy on the daily, right? But I think one of the first support we didn't know, like I actually was also alone in the ER with my daughter, and we were told this, and kind of right off the bat, they were like, here's this thing. I've never heard it before. And they kind of told me about the rule of thirds with people with this condition. Like, you know, I think in layman's terms, like a third get better, a third get worse, and a third stay the same. And so that was kind of what I had to go Google on, I guess, in waiting. But the first provider that came to see us after we were admitted was the chaplain. And so I guess looking back on that, like my initial reaction was like, is my kid leaving this hospital alive? Like that was the question that I didn't want to ask, but I had. And I'm a social worker, like I'm a licensed social worker. And in my mind, I know there's social workers in that hospital. I have peers that I graduated with that work there. And maybe that should have been the first provider to tell us, these are, you know, like you just got this diagnosis. Here's all of these different supports that we have in this hospital. And honestly, I don't know if we saw the social worker but one time. And the chaplain often came to check in on us. And I'm thankful, that was very sweet and kind. But the role of the social worker is truly to connect families to all of these different resources and services. And I think it was one of the days we were there that I was literally Googling and stumbled upon Children's Cardiomyopathy Foundation. And I think I got the message from Eugenia while like late night in laying in the crib bed with my daughter to join the Facebook group. And that's just because like that's kind of my character and my personality type is to like try to find the resources and the supports, but not everybody's like that. So I just kind of wanted to circle back to some of those things that our hospitals already have the resources. They have the social workers there and should probably be the ones tasked to do those things, maybe before the chaplain or side by side or, you know, something. So yeah, I think that was it.
Before I go on, in listening to this, a couple of years ago, a lot of our research, my group has been focused on trying to achieve the greatest quality of life for children with cardiomyopathy and their families. And we published with support from the CCF and the HLBI that parents' perception of their children's health and well-being was stronger than any measurement of ejection fraction or blood test as to how their child was going to go. And then we had another very large NIH grant that looked at stakeholder perspectives on addressing what a lot of parents are concerned about. They always want hope. They want, you know, but they're always concerned about adverse events. And And so one of the things we found and we published, and it was one of my trainees' PhD dissertations, was the lack of alignment and the absence of a central owner of these previously unrecognized hurdles to realize really what needs to be communicated, how we do this, to get the desired systemic improvements is a real opportunity. And we were suggesting, similar to what we're doing today, that future initiatives aimed at improving quality of life and outcomes for patients receiving care for cardiomyopathy through the improved use of information must address this through innovative collectives and novel leadership strategies. So in essence, all of you are training the trainers, so to speak. And we really, again, our work has shown the greatest predictive value of which kids are going to do well is what their parents and families really feel on validated quality of life instruments. With that, so there's the biopsychosocial model that we're talking about here, but there's really a science to this too, and we think that's a real unmet need here for pediatric cardiomyopathies. So with that, Nadine, you want to spill some of your wisdom on this topic with the parent as the project manager?
Yeah, thank you. I mean, there's so much in what everybody has said. It's really important to be listening carefully here. I think the first thing that really strikes me is how there truly is no one size that fits all. And tailoring our care and the education and resources that we provide to individual children and families is really important and also not easy. And I think a lot of the time we don't recognize that second half of the equation. I think the language that we use to talk with children and families about their heart condition is tremendously important. An example I come across a lot is the term heart failure and what hearing the words heart failure can mean to a child, and how that can be internalized as me failing as a person, as a child, and how we can reckon with the conflict in the words that we use medically and what they can mean psychologically and emotionally to children and families. I think another thing really closely associated with that and very linked with a lot of the things that Renee shared was the tremendous and intense fear, anxiety, sadness, anger, guilt, grief that parents feel both at the time of diagnosis and often well beyond that. And when we think about psychological care for children with cardiomyopathies, we often don't include their parents, other caregivers, their siblings, and creating models that include the family as a whole is something we all need to work towards. Most of the work that we do in this space is family-based work, where we are working not only with the child with the heart condition, but their whole family, including their siblings. And kind of overlaid on top of all of this is the idea of trauma-informed care. And so, the trauma-informed approach to care was in so much of what everyone has just shared, recognizing the intense emotions that children and families feel when they're in our hospitals, tailoring our approaches to their unique needs, preferences, beliefs, and values, offering choice at every point that we possibly can, especially choice for children. Do you want the blue Band-Aid or the red Band-Aid? Might seem like a tiny little choice to make. It takes 30 seconds and allows children to feel a sense of agency, autonomy, mastery in their care, which in the longer term will be much more likely to help them advocate for their healthcare needs in the future. So there are a few thoughts and so much more that we could talk about from this, from what's been raised so far.
Great, thanks. Now I want to go on to Kyle's third important point. And what she wrote was managing health at school. So this is a little bit different than the first point. What Kyle was talking about, school-based health plans, emergency action plans are largely variable and rarely medically informed. And providers have the opportunity to keep children in school by creating and providing symptom management guidelines as a standard of care: when to stay in the classroom, when to go to the nurse, when to call home, when to call 911. And without that medically recommended structure, children are being sent home constantly. Also, no more quote blanket end quote attendance excuses. They are being widely overused or misused, and most schools are capable of taking care of a medically fragile child. Kyle, do you want to expand on this, and then we'll see what people's thoughts are?
Yep. So starting this one with a little story too, so you can see where all of the madness comes from. When I was doing that first investigation with the 20 school teams and 17 nursing teams in the state of Wisconsin, I worked with a select group of families to collect the children's health plans in place. And what we found is of like 79 kids, 50% had existing health plans, 50% had nothing. And of the ones that did, the information in them was wild. And the example, if I was like sharing slides right now, the example I share at every conference, I will probably share it at this upcoming one, is an emergency action plan for a child that said it had his diagnosis, and it basically said if you observe like change in mood or attention, use the AED. And it was crazy to me because it was real and it was on file, and it was someone truly believed like this was a good emergency action plan. And that got us kind of digging down into what other kids had as well. And so basically how these health plans are put together is some information is shared with the school contacts a provider that responds. Maybe the child has 4 specialty teams, maybe the child has 1. They take the information they have at the time, also will turn to Google and put together a plan that may or may not meet the child's needs. So that's something that's really important for me as a team, is to help our providers know how to give that information to families kind of right up front. The no blanket excuses, I laugh when we talk about that, but what we're finding is schools are just saying, like, it's easier if the child isn't there in some cases. So that the blanket excuse is like, okay, everything's fine. And we need our kids to be in the classroom every day, all day. So the no blanket excuses and being just really clear on maybe our kids will have more frequent illnesses and maybe they'll take longer to recover. Also, every illness does not require a doctor's appointment. So making sure that 2 or 3 days are still excused, even if I didn't go to the doctor for 2 or 3 days. Having clear guidelines on that information coming from a provider, and helping schools know that like every single tummy ache or headache, we do not need to send them to the nurse. Maybe we take a rest for 15 minutes, maybe we have a snack or a drink of water. Then what's the next step? So what happens if symptoms resolve? What happens if symptoms persist? And so everybody's doing the right thing to keep the child learning with their peers as much as possible is really important for us.
Very good. Renee, does this strike you in ways you want to comment?
Sure. So we've had instances when Benjamin was younger where it would be the scenario of, well, we just need to send him home. We're worried he's got like a little bit of a cough, because similar to Karen's son, Ben does also have asthma. And what we ended up doing that helped with us, we had a conversation with our provider, with Ben, once he got a little bit older, to where we really put him in control of it and said, these are the things that you need to look for. You know yourself the best. And you decide when, you think you need to stay home or when you need to see the nurse. And let me tell you, that kid has not taken advantage of that one time. It's also been really great because it's starting, with him being 13, you're starting to get to where, gosh, he's going to be in college in several years and he's going to need to be thinking of this and be cognizant and taking control of his own, healthcare. And our doctor was really helpful and having that one-on-one conversation with Ben and letting him know, hey, Ben, when you're exercising, do you have this happen? And if you have this, then you need to do that. And it's really helped avoid those school scenarios outside of the pandemic. I mean, that was a whole different thing, right? When we were all trying to navigate that, especially with a CCF kid. So that's been helpful for me. I realize that won't be the case for everyone. I mean, Regina's daughter's still very little, but that change has really helped improve his attendance with school.
Very good. Karen, do you have thoughts on this?
Yeah, very similar, in the fact that my son was 13 when he was diagnosed. And so, we've been very open with him about, what are the things you need to look out for? What are the things that are maybe not problems? And knowing that, the parents are not always going to be there to swoop in, or the teacher may not always be there to swoop in at gym time or something. So we've tried to educate our son on, what to look out for. And as a teenager, I mean, you're not going to have that with a 3-year-old yet, but as a teenager, he wants to be like everybody else. He doesn't want to be different. So, he wants to kind of understand and be educated so that he can react if he needs to. And, we've had, we've had really good providers that have told him, things to, where are your limits, what to look out for. And that's been very helpful to my son. And again, age makes a big difference to help out there. So.
Regina, that last point was important. Age makes a big difference. Do you have thoughts on this?
I mean, in talking about, like, I love being able to teach our kids how to advocate too. And I think the thing with Emmy is that she's so young, and we didn't honestly, even looking back now, notice any sort of outward symptoms that something was wrong, because Emmy had been sick for about 1.5 years before this happened. And we were kind of led to believe it was like something else was going on. No one ever thought, like, let's check in with a cardiologist necessarily. And so she had this chronic cough, and we were seeing a pulmonologist, and he was kind of like, everything's great in his world. She doesn't have cystic fibrosis. Her lungs are clear and functional, but he was also like, something's up here, right? And so, being able to teach her how to, understand her own body, I'm sure will come with age. And Emmy has a lot of developmental delays at this time, and we don't know how, that will continue to impact her in the future, if any. So I think that's always a little bit of a concern on my part, is her ability to understand and really kind of process everything that's going on so that she can continue to advocate for herself. But I really enjoy hearing Karen and Renee talk, because a lot of times I'm like, I don't even know what questions to ask. Like, if it's too hot and humid outside, is she allowed to go outside and play? Like, I don't know, And so it's helpful, I think this connection to the foundation is so helpful for me in being a new member and having a young kid diagnosed, because it helps, doctors kind of give you the medical stuff, but what do we take home to then relate to the family, the caregivers, daycare, the schools, so that everyone knows how to take care of her and look out for her until she's able to also do that for herself. So it's just kind of brought up some questions in my mind to jot down too, to be able to ask our cardiologist for the school, so we can then inform the school.
Gina just put in the chat, for those of you interested, Cardio What is another great resource, good for explaining cardiomyopathy to younger children. And she put the link in. Then there was some really important points in the chat. I think Joseph Hillenberg really brought up a really important point. His son had dilated cardiomyopathy, had a heart transplant, but the issues are similar. And I think the important point is, when I have the privilege of caring for a child and working with a family who's newly diagnosed with cardiomyopathy, we're always looking to achieve the highest quality of life for that child and that family over a lifespan. Why do I say a lifespan? It's a lifelong diagnosis. We might be able to treat somebody, get their ejection fraction back to the normal range in 6 months and say, have a great life. But this is in many ways a lifelong diagnosis. There's different stages. There's different ways that people react. And I think, just before I ask Nadine again to comment on this point, Kyle wrote earlier, teaching the self-advocacy is so important. That's awesome. That was in relation to when Renee and Karen were speaking. And then Joseph Hillenberg wrote, I chose our district because of their reputation in dealing with fragile kids. I realize this is a matter of privilege, but many districts are just not up to the task. Since not all families have that option, sometimes other resources, hospital, PCPs, nonprofit equity advocates, legal resources may help. In Chicagoland, we have a nonprofit whose purpose is pro bono health equity work. And so, again, the points you're bringing up really touch almost every family going through this. And that was the point of us having this learning session. So the more we think that, oh my gosh, nobody walks in my footsteps, that's true. And it is one of the most insulting things a provider can say to a family, is to say, I know exactly how you feel. No, you don't. You've never been there exactly in my situation. But there's enough commonalities that bring folks together. So these comments that our panelists are making and the chat in the chat room is so valuable. Nadine, do you have thoughts on this in terms of equal members of, in terms of what we're talking about now, in terms of managing health at school?
Well, if it's okay, I'll pick up on something you just ended with, which I think was so powerful. And that is that while we may not have walked in the shoes of parents or children, we can go a long way to recognizing those commonalities and normalizing emotional responses to diagnosis and treatment and different points along the care trajectory, and sharing what we recognize are other families' experiences, and then taking it that one step further, which I think is the most important step, which is asking, how has this been like for you? So recognizing there's commonality, normalizing that experience across families, acknowledging there's a community of families who have had similar experiences, but then being deeply curious about, for you personally, what's this been like? And I think for many families, this can sometimes be the first time that they have ever been asked what this is like for them, and can take a little while to get used to. And I think what we can do in the meantime is offer connection, which is, I think, what Joseph has been sharing as well in the chat. Connecting with other services, letting families know that we have a social worker or a psychologist or other resources connected with our team who we know and trust and work with, who can help as well whenever the time feels right for them. For us in our research, we found very similar to you, Dr. Lipshultz, that some of the strongest predictors of children's health-related quality of life were a sense of support from the community that the family has and can engage with, and then parents' own psychological well-being. And I think being mindful of creating those connections and offering those supports is part of what we need to do on a day-to-day basis.
Very good. Thank you. And then the fourth of the fifth points that Kyle was kind enough to put pen to paper and stealing all her thunder. And that's okay. Great ideas need to be stolen. Is equal members of the care team. And before I ask Kyle to expand on this, it reminds me a few years back when I was chair of the Department of Pediatrics at the University of Buffalo Jacobs School of Medicine. Our two pediatric chief residents decided they wanted to do a quality improvement project. And it was interesting because initially there was really mixed feelings about it. There were some people that said, yeah, you shouldn't do this because it's going to slow down rounds in the hospital. Others said, no, families can't deal with all of this. We have to be maternalistic, paternalistic, protective. The plan was that the chief residents were pushing was we want to have family-centered rounds in the pediatric intensive care units as we are rounding on the children who are critically ill. And we don't want to talk outside the room with the door shut. And we want the family engaged with the discussion. And like I said, it was actually pretty controversial. Those chief residents wound up presenting that, writing up the results. Our children's hospital has an independent marketing firm that routinely, with every discharge, creates what's called HCAPs. These are families' assessments of how was the experience, what was the quality of the care, would they feel comfortable going back, would they recommend this to somebody else who had a sick child? And there was a dramatic increase, totally independent, in the HCAP scores when this was implemented. And what the chief residents found is it actually didn't appreciably increase the rounding time, because the bigger concern was if we don't get to some of the sickest children until 1 o'clock in the afternoon, then we might be harming them more that way, so there's always trade-offs. So I bring this up because as I was reading what Kyle wrote here of equal members of the care team, where Kyle wrote, many healthcare systems really focus on health literacy and ensuring that they are speaking and writing at a level that all families understand. In an effort to be more equitable and accessible, information for all families tend to be dumbed down or not shared due to assumptions that families will not be able to understand, process, or apply it. Instead of talking down, we need to be scaffolding learning up. And that, again, is one of the reasons why we are having this learning session. And it's also, I can tell you, for the first 3 international conferences that I've had the privilege of founding and organizing for cardiomyopathies in childhood, it was by invitation only to select group of some of the thought leaders in the world on pediatric cardiomyopathies to share best practices medically. The last one we opened it up to the world. This one, not only is it open to the world, but we're specifically having, whether you're an advocacy group, whether you're a parent, whether you're a patient, whether you're a provider, whether you're a member of a care team, it's open door access. Maybe not everybody will understand, but this whole idea of equal members of the care team, I think resonates strongly, at least for me. So Kyle, what were you thinking about with this?
The cool thing about this one is I think it's come out in every single other question we've talked about it, which really means like this, in my opinion, this is the core of everything we're talking about. In my experience, so, you know, we run things by our health literacy team in everything we do. And I think that's really important. Actually, I can't stress enough how important it is for meeting every family where they're at. The problem is when we presume every family is at a level that might be lower than they're at, or where they're much more capable of doing something. And I believe there is a huge bias that families, especially maybe with lower health literacy levels, are actually much less capable than they are. In many cases, they're taking care of very medically complex children. They're managing very complex medication and equipment, and they're doing so just fine. So really pushing our providers to meet a family where they're at and giving them all the information that's important and valuable to that family at that time is absolutely key. And I didn't have such a big soapbox about this until recently. We've been, Children's Wisconsin has been hosting a school success coaching webinar series. And we invite everyone. We invite medical providers, we invite school teams, and we invite families. And when I get our evaluation surveys back after each session, our providers tend to score us lower on our accessibility scores, that maybe we went too fast, had too much information, or rated the session just as a good level. Whereas I promise you 100% of the families, which is much more heavily families, are rating it perfect pace, perfect amount of content, just right or excellent level, which tells me that families are much more capable than what our provider side might be assuming. So that's a little soapbox message I have for providers, but really making sure the families are getting what they need and we're giving them to the top of their level versus the bottom of their level.
Very good. Renee, you want to share thoughts on what Kyle was just going over?
Her comments certainly resonate with me. I've seen so many echocardiograms that I can actually pretty much read them now. So I know when we're in that room, is it looking good? Is it looking bad? My only...
I'm worried. Competition. This is not...
You're on. No. I think the one caveat I would make is make sure you're reading the room, because if it's very early on in that diagnosis, and I know when we had the initial conversation preparing for this, Dr. Lipshultz, you talked about how a lot of times in that initial diagnosis, families, I mean, it's just going over their head. I mean, it's just like a blank stare. And that might last a few days. I mean, I know it did for us. I mean, we had people coming in, it was just a rotating door of different folks, talking about genetic testing, and which I didn't get to talk about earlier. And then, what is his medication regimen going to look like? And, we also heard the rule of thirds, and it takes a little bit of time to absorb that information. And then, you can kind of tell when it turns and the family's, empowered now, and, give them that information, give them prompting questions sometimes too. One thing that I want to stress is there's no such thing as a dumb question. There were numerous times where I'm like, I don't care. We're talking about my kid here, and there's nothing more important than that. And it's up to the providers to set the tone for that conversation and make those, make the family members feel comfortable to ask any of those questions. And then again, having that once, the child is old enough, having that conversation with the kid, sitting down and addressing them. What questions do you have, and how have you been feeling? And do you have any worries. And you can help get that family to that higher level of education. So I completely agree with Kyle.
Very good. Karen?
Yeah, I think after the initial diagnosis and going through that shock, I think then I know for us, when I went back in, I came back in after I'd had time to do some reading, I came back in with a list of questions. And I have to say my providers, I didn't feel rushed or hurried or anything. And I didn't really care either because I was there and I had them and I was going to ask everything that I wanted to. I wasn't worried about, you know, us not knowing because we're not medical people. So I just continued to, I guess, learn along the way, read along the way. And then the other thing that helped me as a parent is to, I know this sounds crazy, but to join some of the cardio Facebook pages where I could read some different stories of people, families going through the same type thing. And I actually reached out to some of the people making comments about their children and talked to them. And that helped out a lot. But you kind of have to do these things when you're ready. Like initially you're learning, then you learn more, then you have more questions. So it's a whole process going through there. And I think the medical providers have to understand where you're at in the process on, what you're ready to know, to learn more or know more about at that time. So that's kind of helped me move along, you know, to to go forward with where we're at, at any given point.
Thanks, Karen. As you were speaking, Gina put in the chat that CCF has compiled a list of questions for families if they find it helpful at medical appointments. And she noted that she's happy to receive suggestions for others to add to this list. Again, the whole goal at CCF to help. And that's where, again, listening sessions like this help us be even more responsive and helpful, not only for you and your families, but for everybody else. That
Right.
I wish I could tell you that the cure is around the corner. The more we study, the more we learn at how many different causes there are for cardiomyopathies in children, and the course and the treatments and the symptoms really vary based in many ways on cause and things like that. But a lot of these type of questions, as we said here, there's a universality, there's a lot of commonality, and so the more everybody can share, the more CCF can be a resource for you and other families. Along those lines, Regina, your thoughts?
Yeah, I just wanted to piggyback off of something that Renee mentioned about kind of doctors kind of having, I guess, preemptive questions for families who maybe are still in this place of like, we just got a diagnosis, we're still trying to process, we don't really know what questions we have yet. I think the adult version of me, I will ask all the questions, maybe, Gina, younger version, I didn't, and I was always worried in school. And so, I don't really have that sort of like worry, fear, anxiety around asking anybody any question, or even saying, I don't know this answer, I'm going to ask. But my mother-in-law, we've had some issues with my brother-in-law in medical, and she's actually brought me along to appointments with her because she won't ask. And so I imagine her being in my situation and literally not asking a single question. And in those instances with people like that, it would be so helpful for the doctors and providers to sort of have kind of these questions already lined up to say, like, do you have questions about this specifically? And one thing that popped in my mind was like restrictions. If a doctor had placed a restriction on my daughter, they would have told us, right? Like, your daughter can't do X, Y, and Z. but it may also be helpful to say, even though there aren't any restrictions, they didn't give us a restriction, it probably would have been helpful in my mind to hear the doctor say, there are no physical restrictions or limitations on your daughter right now. She's able to resume life, her usual running, playing, all of these things. Because then I go home and I forget, I'm like, oh my gosh, we just set up our play yard outside. Is she allowed to run around? And actually the no stupid questions, I had a chuckle because the one question I had before we were discharged was, can my daughter go to Disney World? And I knew it wasn't a stupid question. I needed to know because we were supposed to leave in 3 weeks for this pre-planned trip to Disney. And I just needed to know, like, is she in a state where she could make that trip? And also it's Florida and hot. And then the other one was, my daughter went from taking 1 hour naps to 3 hour naps. And I was like, this is a huge change. Like, is this, so that was my question, that like, there isn't a stupid question, but I wonder if some people might also feel a certain way about asking something that seems so small and minuscule. But in my mind, I'm thinking that's a big chunk of a day and a jump in a nap time, and she's exhausted from working hard, so she has to take these naps. But I just kind of wanted to share that too, on maybe doctors already having some preloaded questions already. Like, I know we didn't say that there are any restrictions, but just so you know, like, they are not restricted at this time. They can resume life per usual, or the reverse, obviously, if there are restrictions.
Excellent points. And your example where, you're recognized as a family member that can really be there to help and ask those questions and not be flustered as a provider. There's actually pretty extensive pediatric literature that when your child's doctor comes in wearing a white coat, it increases anxiety and it makes it a little bit harder. And sometimes coming in with a tag list of questions makes you easier. In the field of childbirth and pregnancy, this is very well accepted in cultures around the world, having a doula, a doula, where it's somebody that can provide emotional and physical support, going through this. And, I, like you, had the privilege of accompanying actually a number of my patients and families through the years to other medical appointments, just because when requested, having somebody that can help express what really sometimes people have a hard time expressing can ultimately be of benefit. Nadine, your thoughts on this topic? Before I do that, since this topic is really about having equal members of the care team, Gina, I just want to mention, I don't know what it means, but when I look at the screen of the 7 speakers, I might be the only cardiologist, but I'm the only one that's backwards and on the screen. So does that have any significance?
You look good to me. It's not backwards on my screen, so you it's not displaying that way.
Yeah, no,
but no, it wasn't done on purpose.
All right, I just thought I'd put a little bit of humor in. My kids always say, Dad, you try to be funny, but you never are. So there you go. Nadine, what are your thoughts?
Well, it's hard to follow that. Bravo to your chief residents. I mean, that was fantastic, and their persistence in getting that work done. I think if we have the hope that, and we are aspiring to and have a wish that caregivers are the project manager, as Carl was saying earlier, then we have to be modeling this. And if we're not having family inclusive rounding, parents aren't able to see those models, and I think those are really important. When we develop resources for patients and families in our center, they're all co-designed right from the very, very beginning. So the resources that we choose to create are guided by what parents and families and children tell us they want and need, and then they have an equal, if not more elevated seat at the table in terms of how we design those resources. Wherever possible, we're using patients and families' own words in the resources that we develop, so that we are bridging those gaps, and so that we're all speaking a language that is common amongst us. We did a study some time ago now where we looked not only at health literacy among families of children with heart disease, but also e-health literacy. So how parents were making decisions around the kinds of resources they could use and trust online. And I don't think it would be a surprise to any of us that the main finding of that study was that e-health literacy levels were really, really low. And so one of the things we recommended in response to that was that care teams provide information prescriptions. Be able to provide a list of resources that we've looked at, that we think are credible, that are reliable, and just know that you can always come back to us and ask questions if there's anything on there that you're curious or want more information about. And I think the more we partner in the information resources that we create, the better they'll be. And I think CCF is certainly leading the way on that. Question prompt sheets are really important. Not all those questions will be relevant, and making sure we scaffold the question prompt sheets with that kind of information. If some of these won't apply to you, and that's absolutely fine, and there might be some on here that aren't on here that are important. So we're always learning and evolving together, and I think that is the way to go.
Great. Freya Sakamoto wrote in the chat, I find that when I reach out to my son's cardiologist through the portal, it's always his nurse practitioner that replies. I have the sense that she is triaging, and it's frustrating. It is not clear to me that she is even checking in with the doctor. This is something I plan to bring up at our next visit. Perfect. That's exactly what we're talking about here. As you go between visits, certain things really require more immediate attention, but putting together a tag list of questions or concerns that you can take the time in your face-to-face visit to bring up is important, because I think every family and every provider is different. And just like with all relationships in life, you have to work on those relationships. I mean, it's a care team. And along those lines, Kyle wanted me to mention that there's an upcoming school success coaching webinar series. It's a 6-part virtual webinar series running from September to November 2024, 1-hour sessions with dates and times to be determined. That's open to all families and caregivers, providers and school staff included, of children with chronic illness. The participation is free, but registration is required. Kyle, you want to just spend a little time explaining that more? Sounds like it's pretty relevant.
Yeah, absolutely. It's not intended to be a shameless pitch. It's a totally free thing. But the cool thing about it is we were kind of holding it at Children's Wisconsin and running it in spring and fall. And at one point we sat down with our leadership and said, there's absolutely no reason why anyone can't participate. Why is it Children's Wisconsin families only? This information is relevant to anyone, specifically in the heart world, but also we cover all chronic illnesses as well. So it's like Dr. Lipshultz said, it's 6 sessions. We cover all different parts of that school journey, from, okay, we're starting, maybe we're concerned about some developmental milestones, to long-term planning. What does that look like for college and beyond? And like I briefly mentioned earlier, it's been really good. We're getting some really great feedback, and I'm getting so many emails of families saying, like, I tried that and it worked. So again, not just for families, but school teams are invited and providers are invited as well. And we're just putting our flyers in our clinic offices, and those families who are interested pick them up, and those who aren't. And it's been a great time. So just wanted to mention it to invite anybody on this call who's interested, for themselves or for their patients and families.
Good. In our remaining 4 minutes, there are two things I really want to do. One is a housekeeping task, and then the other is hopes, dreams, and wishes. I'd like each of the participants, before I call on you, to do a 30-second soundbite limit based on this hour and a half. What do you think would be the most important next steps for including a lot of this content in the 6th International Conference on Cardiomyopathies in Children in May? But before that, I want to put a plug in because the CCF is a very humble organization. It's grassroots. It was started by families whose children had cardiomyopathy. A lot of the research that has led to advances, a lot of the webinars such as this, a lot of the learning materials, the conferences have come out of bake sales, poker tournaments, golf tournaments, people responding to, and they're never going to say it, but as a provider, let me tell you, this has made a world of difference to have families and foundations and people they know contribute, because this partnership, when I started in this area, we really didn't have outcomes that were that different than they were in the 1940s. And by all working together, we have a lot of successes. One of the CCF supported studies cut failure of medical management, needing a heart transplant, or dying for kids with dilated cardiomyopathy by 50%. And it was by learning collaborative, by people talking, working, having these international conferences and other things. So I bring this up for each of you, because again, it's a very humble foundation, and they're not going to directly ask the way I'm asking. So, if you know people that might be interested in helping to support CCF with these activities, please let CCF know. Again, I just try to help because it's so important. And we really only have a minute or so left. So I said I was going to go around the horn. I'm not. But for the panelists, I would really like you to, again, reflect a little bit, share with Gina and myself, how we can learn from this to make the May conference as inclusive of these thoughts, these ideas, this content as possible. And for each of you that we're willing to be panelists here and share your thoughts, your wisdom, and it truly is wisdom. It's not just hyperbole. Truly appreciated. And for those of you that have participated as members, I really appreciate that as well. So right now, I always like to end my conferences on schedule and on time. So, right now where I am, it's 1:30. We're right on time. Have a great day, everybody. Thank you so much.
Thank you.
Thanks, everybody. Thank you again for your participation, and thank you to Dr. Lipshultz for moderating us. Thanks, everybody. Bye-bye.
Thanks.